All right. Good morning, and thank you all so much for allowing our technical difficulties to not deter you away from this broadcast. My name is Sean Torres, and I'm a SIBA specialist with the Latino Commission on AIDS, located in New York City and in the South, out of our South Carolina office. And thank you all for joining us today. HIV remains a public health concern in the United States, with the southern states carrying a burden of this public health crisis. While great progress has been made in improving the quality of life for people living with HIV and AIDS, there is still much work to do. An estimated 1.1 million people in the United States were living with HIV at the end of 2015. And of those people, about 15%, or 1 in 7, did not know that they were living with HIV. And that's a statistic from the CDC from 2017. Testing efforts throughout the nation have aided in helping people become aware of their status. However, of the 86% of persons who are aware of their status, 75.9% are linked to medical care, while 49% are actually retained in care. Today, we are lucky to have providers doing this work on the ground to discuss how the effective testing programs have been vital to ensuring clients reach viral suppression through appropriate linkage services. I would like to welcome our panelists. We have Sarah McClam, who is the Care Coordination Program Manager at Palmetto AIDS Life Support Services in Columbia, South Carolina. We have Katie Connor, who is the Linkage to Care Coordinator at Crescent Care in New Orleans, Louisiana. Excuse my tongue this morning. And we have Levy Rosado and Frank Juka from the OIC's LGBTQ Wellness Center in New York City. And both of them are HIV CTRS specialists. I gave a little bit of introduction, so now I'm going to ask each of our panelists to introduce themselves a little further. Anybody can go when they want.
I'll go first then. So hello, everyone. My name is Levy Rosado. I work with the Latino Commission on AIDS, but I'm more specifically located at the Oasis LGBTS Wellness Center. I am an HIV counselor, tester, and referral specialist.
Hi, everyone. My name is Frank Joka, and I work with Levy at the Latino Commission on AIDS, and more specifically at the OIC's LGBTS Wellness Center. So I am also an HIV counseling, testing, and referral specialist.
Thank you and welcome. Sarah, if you're talking, you have to unmute yourself.
That's better?
That's better.
Okay. As Sean said, I'm Sarah McClam, and I work with Palmetto AIDS Life Support Services. I am the program coordinator for care coordination, and I provide linkage to care for people who test positive for HIV. I've been working with PALS for 23 years.
Thank you and welcome, Sarah.
Hi, I'm Katie Connor, and I'm the Linkage to Care Supervisor now at Crescent Care. And I started here as a patient navigator a little over 3 years ago. And now the program has grown. And yeah, we're down in New Orleans. We used to be the No AIDS Task Force. And now we're known as Crescent Care because we're now an FQHC. And so we've expanded some of our medical services to include other things besides just HIV. So happy to be here.
Thank you so much and welcome. I count it an honor to be able to moderate this panel because I have worked with some of these people who are on the panel, and I have provided capacity building services to other persons who are on this panel. So it is wonderful to be able to facilitate this conversation with you all. And we're not going to delay the time. We're going to go ahead and get to the questions that we have. So the first question that I have for our panelists is, how does your agency define linkage?
Well, our organization defined linkage as when after a client tests positive, when the client have the initial visit with the provider. That is considered linked to care once they see that provider for the first visit.
Okay.
Yeah, it's the same for us. When I started, it was based on the blood draw, because that's how the state monitors whether somebody's linked to care, is when they get a viral load drawn. But now we're definitely doing it on when they see the provider, in terms of for our purposes, and they get their labs done that same day for us anyway. So there's not going to be a difference there, but we think the provider appointment matters as linkage.
Yes, so pretty much the same. We define linkage as someone not only seeing their provider for the first time, but also getting their labs read. So that's how we, how we define it. Yeah. Mm-hmm.
Okay. Thank you, and thank you all. And we'll talk a little bit more and delve into the different types of linkages later on into the conversation, because I'm noticing that everybody is talking about when a person is linked to medical care, but then we'll talk about what other linkage services and referrals that can be offered to our clients. Okay. So our second question, what are some factors unique to your specific location that, one, make it easier to link newly diagnosed persons to care, or make it more challenging?
Okay, so I would say for us, one of the things that makes it easier at Crescent Care is that we have a very large testing program. So while we provide the medical services, we also are doing a lot of the testing in the city through different, we do it at our clinics through walk-in testing, but we also do it, at certain bars and different locations like that. So having the testing be part of our own organization is helpful in terms of linkage, because it's one of our own employees that knows to call the linkage person, and the paperwork stays with us, and that sort of streamlines that process. And also is that the person doing the testing understands what our services are, and how the linkage should work. I would say something that makes it more challenging is New Orleans in general. There's not very much public transportation that really works very well. And there's also a lot of stigma, like everywhere else, I think. So I think that makes it really hard to get people into care and get them tested in the first place.
Okay.
With PALS, I think what makes it easier for our clients to be linked to care is that we are located in the center of the bus line. So transportation is easier for our clients to access, as well as we do in-house testing, and we always have a linkage coordinator or case manager on site to speak with that client, as well as an MA that provides us with getting all the labs that's needed before the first visit.
So for us, one of the factors that makes it easier for us is the fact that we are in the heart of Manhattan. And a lot of the things in Manhattan are very easily accessible, whether if it be walking, public transportation, a taxi, things like that. So it makes it very easy for us to link clients to care. Our partner is literally a few blocks away from us. So it's, clients are usually linked to care in less than a week. So, and one of the things that makes it challenging for us is that we're not the only CBO, we're not the only testing area we're not the only testing place in the area. So that's the only challenge we have.
Right. Thank you for bringing it up, right? So like in certain places where you're in New York City and there's an oversaturation of places that provide the same services, that could become a challenge for you all linking persons to care, right? There might be another testing facility right around the corner, as if you're in like South Carolina, right? Where you're one of two different places that link persons to care or that provide these types of services. So it might be easier to link. However, when we look at New York City's transportation, right? I mean, buses, subways run 2 o'clock in the morning. When you're in South Carolina, even though you might be on a bus line, those things might stop or slow down a little earlier, right? And in New Orleans, which is like both city and country at the same time, right? It's just a blessing and a curse where you're just able to like have all of those different bars and venues where you can provide testing and then also link persons to care. So thank you all for bringing that up. So I want to talk back to Katie just for a moment. You talked about something that might be more challenging. Can you expound on that, why that might be challenging?
Are you referencing stigma?
Yes.
Yeah, okay. So, I mean, one of the things that I think is recently more helpful is that we've moved into a new building. Mm-hmm. The building that we were in for years and years, people kind of knew in the neighborhood also that that's like, oh, that's the AIDS building, mm-hmm. right? People wouldn't want to come in there to access care. And we tried to, you know, get creative about what we could tell them they were there for instead, or things like that. You know, really try to push like, no, just tell them you're on PrEP, you know, or whatever. And it was also like across from the courthouse and the jail. So that just like that great of a place to be. But yeah, I mean, I think that, I mean, we're in the South. I mean, there's stigma for everywhere in the country when it comes to HIV, but yeah, we're in the South. And I mean, in terms of sexual orientation, you know, that's not always very accepted. And then also, you know, I think that for a lot of the men down here, you know, it's just, they're not going to be out about it. And so also trying to get linked into care makes that more difficult to like have those conversations with their family. But I do think that since we became an FQHC and have these expanded other services, that's made it a little bit easier that we're not just an HIV treatment facility anymore. So I think that's helped a lot with the stigma and for getting people into care. They could just say they're just going to like a regular primary care appointment and things like that. So I think that addressed that. Also, you know, changing our name, because like who's trying to go to the No AIDS task force? You know what I mean? that was good back in like 1989, but like now, you know, care is just a better blanket term. So I think some of that stuff has been helpful. I don't know if I answered your question.
No, you did. So like, thank you for bringing that up, right? Because one of the things about being a client-centered agency is you take into consideration the, some of the barriers that clients present, right? So walking into an agency that says no AIDS, right? It's stigmatizing, can be stigmatizing, right? And we see across the country, a lot of these agencies are moving towards an FQHC approach, right? Which offers those other services outside of just HIV care, right? And for agencies who might be thinking about moving to an FQHC, I think this might be helpful thinking and talking about stigma. Thank you. And now, Sarah, one thing that you talked about as that might make it easier is you have into your contract, you have a person who is on staff that can do blood draw on site.
Yes, we have a medical assistant on site who's able to go ahead and draw all the labs that's needed for first visit, as well as able to just make the referral and give the client an appointment at that point in time if the client is ready to move on into linkage.
Mm-hmm.
And one thing Katie said, she talked about the location, and it make on our side it's a little easier because we are sitting in the middle of around 4 or 5 different businesses. So if you pull in the parking lot, nobody will never know where you're going. You're just walking into a suite. You know, if somebody don't watch you walk into the suite, they won't know. And then our organization, we don't have a name on the door or anything like that.
Right. Thank you. Right. So those are other things to consider when having these services and linkages, right? That is, there are big AIDS sign on the door, right? When you're using your company's vehicle, are you running around or driving around in the van that has a HIV ribbon on it, right? Or are you driving in plain vehicles that have no insignia on it, right? So these are things to consider. Thank you. So what programmatic activities and policies are in place that aid into the linkage efforts?
Well, as I just stated, some of the activities that we always have somebody dedicated to linkage to care doing testing, during the testing times, days, clinics. We have the Adams Place Clinic in the afternoon, non-traditional hours. So we always have someone here who can provide linkage to care, as well as we have someone on staff who are available to assist that client in that first appointment. We also provide transportation if the client needs transportation, and just not asking for someone to come with them to appointment.
Thank you.
I would say definitely the clear biggest thing that we changed is, well, there are two programmatic things that help with our linkage efforts. One, in Louisiana, we were able to get the state a couple of years ago to approve a rapid testing algorithm as counting as a proof of diagnosis, so that somebody didn't have to wait and do a blood draw. So that enabled us to link faster, because from that first day of doing the finger stick, we just do 2 different ones, and now that counts as a confirmed result. Now they can go straight to the doctor, like there's nothing holding up those results. That was a big one that I've noticed from going to conferences. Other states don't have that, and so they still have to do a blood draw and things like that. And then the big program for linkage is that we started a rapid start program that we call the Crescent Care Start Initiative. And so what that means is that our goal is that when somebody gets newly diagnosed, that they see a provider and get started on meds and get labs done within 72 hours of diagnosis. And we do a lot of them same day. So that was a big programmatic change. And we were able to get Ryan White to pay for the first 30 days of meds. So just hand that to them on that first visit. And also the fact, this isn't something that we did, but it affected everything, is that they expanded Medicaid in Louisiana. And so that was able to give us more support for the clients to get covered in the future. And also was able to, we got so many patients on that then we were able to use Ryan White funds for other things, because they didn't have to cover all of these uninsured patients. And so, yeah, I would say the rapid linkage, being able to do rapid testing as a confirmed diagnosis, and then having the expanded Medicaid greatly affected being able to improve our linkage efforts.
Thank you.
So as Levy mentioned, we are in the heart of Manhattan, so therefore our resources are very good. Most specifically, our partners, Mount Sinai, they offer IART, which is immediate antiretroviral therapy, and that allows a person who was recently diagnosed with HIV to get linked to medication in 0 to 4 days. What does the 0 mean? It means that it can be within hours. So someone who just got their preliminary confirmatory test can get linked to care within a few hours and get medication for a week until they get the full prescription. So also it is worth mentioning that for this, you really don't need a confirmatory, which is extremely helpful. I mean, I think we know how HIV testing technology has come to. So it is most likely that a person would be a confirmatory positive. So yeah.
Wait, can I ask, what test are you doing that counts that then you're starting people?
Yes. So we use Here Determine, which is Alere Determine, which is a 4th generation test. It not only allows us to identify antigens, but also, not only antibodies, but also antigens of the virus. So that has been very, very, very satisfactory, just within our clients and with our population.
Okay, I was curious because we do that one too, but we've had a fair number of false positives with the Determine.
Really?
Yeah, and so that's why I was curious, because we follow it with the INSTI. We do the INSTI as the second one, which is also nice since it only takes 60 seconds.
Right.
But, and there have been a couple of people, even with discordant test results, that we did go ahead and start because risk factors made sense, and it's up to the medical provider. So if the medical provider wanted to go ahead and start them, then they did. But we've had a lot of determinants with
false positives.
positives. Yeah.
Really, that's
I was just curious about.
right. That is a little weird because I mean, from all the studies that I've seen, it's not only highly sensitive but also highly specific. And so far, we have not had any sort of problem. I think maybe from what I've talked to my coworkers, we had one false positive a few years ago, and it was just one. So in the past 2 months, maybe we've only been using Determine and not InSTEEP just because we were lacking some resources. So there has not been any problem with Determine in these past few months. So yeah.
Okay, that's great.
Mm-hmm.
Now, for persons who are out there watching, we're not telling you to scrap your testing technology at your agency. These are best practices or some lessons that we see across the field, right? There are other agencies that might be using other testing technology, right? But before you scrap anything, those are conversations you have with your supervisors and the persons who make those types of programmatic decisions at your agencies. And if you're that person, right, this is something that you need to have conversations with your staff about, right? About the importance of using a particular testing technology at your agency, but also the importance of CLIA waivers and all of those things, right? So I think, you know, this is a healthy conversation to have, and definitely some that managers need to have clarity on, but also line staff and volunteers. Everybody across agency or across programs need to be able to have these conversations or have the knowledge about these conversations. Thank you. So
I was gonna say I wasn't trying to start anything. I was just curious.
Okay. So listen, it's good to have healthy dialogue, and we appreciate it. Now, what barriers prohibit persons from being linked to care from an agency's perspective?
Well, one of the barriers that I personally had as a tester is, despite living in the tri-state area, we might have some clientele that come from New Jersey, and they might not have people that live in New York to provide an address per se. So that might not be something that prohibits. It will slow it down, because it doesn't necessarily mean that that person will get linked to care. That they might not get linked to care, but it'll slow down a little bit. That's my thing per se.
Okay. Anyone else? What barriers from an agency's perspective might prevent persons from being linked to care?
Some of the issues, yeah, I mean, I definitely say if they don't live in the EMA, that can be problematic. But we don't have that problem too often. And then I would say, I think sometimes like I'm concerned for that first visit about private insurance, because I don't know what the copays might be and like what the bills for labs might be compared to somebody having Medicaid or using Ryan White. And so, I mean, we tend to not charge their private insurance for the first visit because I'm afraid that they're going to get like a $2,000 lab bill or something. But that is a cost to the agency as well. Like, and it's not that many people, but I'd say that's a problem. And sometimes people not being able to report a very good like medical history, or like their testing stuff that they're saying is like not quite right. And then you have to try to call the state and find out like what the testing information is. So like not having proof of diagnosis slows up the process for us a little bit, because we don't want to link them when they don't need to be linked, you know. So sometimes we have to retest them or things like that can slow the process down.
And I can see how that might be an issue for persons who are in agencies in New York City, right? Where people will transplant to New York City all the time, right? When I moved to New York City when I was living there from South Carolina, right? And persons, you know, we migrate. People, that's what we do. We migrate throughout the country, and what might be policy in one state might not be policy in another state, right? So some of them might be able to use word of mouth as a diagnosis, and some might need that actual paperwork as a diagnosis, or proof of diagnosis, I should say. Sarah?
Yes, well, I think some of the barriers with us is having someone who's especially people who comes in previously positive and doesn't have any HIV verification, and we have to test them. If we have to test them again, and that waiting period for them does not sit well with them sometimes, because they're anxious to get into care. So sometimes it's hard to link those folks because we lose them. They've moved on, or even we've seen from an agency perspective that a lot of barriers is people who's in active addiction. It's kind of hard to link to care. We've been trying to get them to just if we can get them in, that's the thing, we can get them in for labs, and it's going to take a while to get them back in for the actual visit to see the provider. So that's been a barrier for us.
Now, the second part of this question is, because sometimes we know that there's a disconnect between perceived barriers from an agency and perceived barriers from a client themselves, right? There's a disconnect. So what barriers might you have heard that a client might have? And I think, Sarah, you and I might have had this conversation recently in the office, right?
Yeah, we've seen, clients, first of all, you talk about clients, stigma is one. Stigma is one of the biggest one. And then clients, it depends on the location. They don't want to come to this particular location. They don't want family members to know. They have fear of knowing the unknown of what it is. And then a lot of time clients don't have have knowledge of the importance of early treatment. That's a big one. We see that clients just don't have the knowledge of being treated early.
I think also for some of our clients, it can be just like work hours and like other priorities. And we try to have like later evening hours some of the time, and we do one Saturday morning. Like we do it every week, but it's only from 8 to 12. So like that's kind of early, I think, too, for some people. But yeah, the people that are like working all the time, or working, and then they also have to take care of their kids, and then it's hard to get in. So I think that, and we try to make the visits as short as possible, but especially if you haven't been in a while, we're trying to get paperwork done, we're trying to get labs done. Like it can also be kind of a longer visit than somebody might want. So I think that is an issue. And at our last building, parking was kind of problematic. So I think that made it hard for, like, people would get towed because they parked in the wrong place and stuff like that. So that was a more minor one, but still, I think that stuff matters.
Thank you.
And for us, I guess for the clientele, I believe it's a perceived barrier of what it is to get linked into care. Like, for example, you might have an undocumented client that says, I'm undocumented, so I can't get linked to care. That's something that we need to reach out and then educate our clientele.
Right. And I appreciate you bringing up the topic of persons who are undocumented, right? Because in our current political climate, right, where persons are, where xenophobia is running rampant in our country, right? And that's something that I pride our agencies in. We're able to have these open and honest conversations around the direction of our nation, right? And how it's not conducive for persons who are undocumented to receive the best quality of care or best quality of health in this country, right? Where barriers are presented to undocumented persons every day. When we look at places like Alabama, where they have laws on the books that says if you transport undocumented clients in your car, you can be arrested, right? Even if you're transporting them to medical services, right? So thank you for bringing up the topic of persons who are undocumented and how health for them or just services to them might be. There are a lot of barriers presented to those persons. Documentation status.
Definitely. No problem.
So I know one thing that we like to do is we like to throw up the glitter for our agencies, or our agency is doing this. This is really good, right? And our agencies are doing good work, right? But I think what's good about these conversations is we're able to be transparent with people, and persons are able to see like, okay, this is where I am and this is where I want to be. And then agencies that are doing well, this is where you were and this is where you are now, right? So what are some areas that you think your agency can improve its linkage processes?
Okay, so,
Oh my God.
So the question was, in which ways, right? Can or has our respective agency improve this linkage process? So I think one of the ways in which we saw that we could improve was to work with our partners more closely. So I think collaboration is key in our in just what we do. So definitely, working with Mount Sinai and the fact that they're able to help us with our ADAP applications or with the IR that I was mentioning earlier, the immediate antiretroviral therapy. And also the fact that we are very much client-centered in the way we navigate people. So we need to know what the needs of the person are. So for example, a lot of our clients are immigrants, so they don't even speak English. So, we go with them to the clinic and we make sure that they get to understand each and every single piece of information that they're told in English, translated in Spanish, and just be with them for whatever time he needs in order for them to get the best kind of service. As Sarah was mentioning, the knowledge on how important early treatment is not really well known. So we really tell our clients that this is important for you.
Thank you.
Yeah, I think I agree. I think one of the things that we do need to improve does have to do with some language services. So we luckily, we just got another medical provider about a year ago who speaks Spanish, which is awesome. And we just got a nurse also. So that's incredibly helpful. But we do run into a lot not having the paperwork in Spanish. And then realizing it's much more work also to try to get a staff member whose job that isn't to do that, has to come and then explain all this paperwork in English to the person or things like that. Whereas if we could just hand them, if we had more of our stuff translated, and we're working on trying to do that, but it's been a very slow process because there's not a designated person to do that, right? So everybody gets busy, and then we're oh, right, this form is still only in English. So I think that seems like a very straightforward thing that could be fixed and improved. And then I would say one of the things that we did improve was that we used to link within 90 days, and then we went to 30 days, and then we went to 72 hours. And that was all in the last 3 or 4 years. So that was a big improvement that did happen. And also being able to link people without all of their paperwork being done ahead of time. It used to be that they had to come in and meet with a case manager, do all of this stuff, and then they could come in a week or two later and meet with the doctor. So it was delaying, them accessing the provider. So we just condensed that, or we worked it out with Ryan White or something where not everything had to be done on the very first day. So I think that was helpful.
Thank you.
And I think for us, I think we can improve by having our provider in more. We have clinic once per month. So sometime if a client, depends on when that client tests positive, they may have to wait almost 30 days, a good 3 weeks to see the provider. So I think if we have, once we are able to get another provider and be able to have clinic at least 2 to 3 times per month, that will improve tremendously, as well as working with our partners who we refer out to make sure our clients can get an appointment within less than 2 months, 3 months out, you know, making sure that they can get an appointment to see that provider soon as possible.
Mm-hmm. Thank you. Right. And all of you brought up, you know, some very important things, right? And all of this like leads back to the fact that all of us need more money, right? If we all had more funding, we could do great things, right? But where there is a lack of funding, that's where most of you have brought up this idea of partnerships, right, with other agencies, right? On our last webinar, Dean Edwards from PALS talked about how they have an intern from the local colleges around who specialized in social media, right? So that intern now is their social media specialist at the agency, and that's a part of their internship, right? So that's the importance of partnerships and strategic partnerships. And we're shifting gears into like that. So the question is, what strategic partnerships outside of your agency are in place to support timely linkage?
Well, with us, we have a partnership with FQHC where we can get our clients seen on the same day, you know, before, like if we can get them there before 3 o'clock in the afternoon, then we can get them linked to care, or at least get them and get an assessment done with the provider, with the organization, so they can get an appointment with the provider. We also are able to, oh, I just lost my thought. Over 50.
Thank you for doing this work for so long. We appreciate it.
Oh my, go ahead, I'll come back.
I would say we do, we have referrals and MOUs with some of the other community-based organizations, especially places that do testing in the city but don't have, like we're also the clinic that they then refer to after they do testing. And having, you know, turnover is always can be fairly high, but we have managed to keep like some good contacts with those places where they know that they can call our linkage person's cell phone and get people in that way. And there's also some other clinics that like do HIV care, but might end up doing testing or doing some kind of STI testing with a patient, and then they'll refer them to us also. Yeah, I would say that's one of the main ones. I have something part, so I'm going to wait for that.
Okay.
So for us, we work with the LGBT Center. We have a navigator that comes to us like once a week to help clients with insurance navigation. We also have our own navigators here that help with NYC ID for those people that are undocumented. We also work with the Latino Religious Leadership Group, basically where we test, we do outreaches on like in shelters and stuff like that, and churches. So basically to help get it, even though like, let's not forget that, you know, sex isn't the only vehicle for HIV transmission. We also have injection drug users or all the drug users as well. So that comes into play as well.
Thank you. And I'm glad you touched on that. And I think I might have touched on this a little earlier too, right? Because sometimes we define linkage as or referrals as linking somebody to medical care, right? But if I'm hungry, an HIV medical doctor might not be my first priority, right? If I don't have transportation to your agency, right, how can I even get an HIV test? So what other partnerships outside of like the medical care field, what we call supportive services, what other agencies do you have linkages with?
I mean, we refer people, like, I was gonna say one of our biggest problems is housing. Mm-hmm. And so we refer people, there are a couple of transitional housing places here. And then otherwise some of the shelters that we don't necessarily have like a a real agreement with. It's just we know what their rules are and when they take people. Transitional housing, our case managers do a lot of work trying to get people into transitional housing, and then eventually maybe some like better long-term housing options. So I would say that's one of the big ones. We have a food pantry here in-house, but it is part of also a partnership, I think, with Food for Friends. So there are some things like that that are like in-house, but are actually sort of another agency. So I'm not always totally clear on that. But yeah, I would say the transitional houses is somebody that we work a lot with, like trying to get our clients in there.
Okay, thank you.
And yes, for PALS, we have a lot of services in-house, such as housing opportunities for persons living with HIV. We also have behavioral health services in-house, food pantry, provide HIV education and interventions. But we have a partnership with Transitions, which is a homeless shelter for people, and they kind of work with us that we can give them, instead of sending a referral over, we can give them a call, and they will, they have so many beds can set aside just for us, as well as housing authority, where we can get so many vouchers for our clients for Section 8. For the Section 8 program. We also have a partnership with the dental clinic, where we can get, when our clients need dental services. So those are just a few of the other resources that we are partnering with others to provide services for the clients.
Thank you.
And one of the things for us is, like, for example, the Human Resources Administration. We also have HAZA. HAZA is like shelter assistance, and they also offer things like public assistance, where they give money every 2 weeks, SNAP benefits, where they give food assistance every month. We also, let's say if that doesn't work out, because HAZA has a thing where you work with individuals that are living with HIV. Let's say there's someone that doesn't. We also have some partnerships with the AIDS, let me see, it's ACQC, so it's the AIDS Center of Queens County. So, like, for example, we have some people that know people, so networking is a big deal as well. So whatever services we might not provide, we work well with others as well. So the key is putting the client's needs first, and not the agencies.
Yeah, thank you. Right. So it's good to have these healthy working relationships with other agencies in your local area, or agencies that might not be in your immediate reach, right? Right, because if you have clients, Levy and Frank, who live in New Jersey, right, it might be helpful to have referral services to persons or agencies in New Jersey as well, right? So those things are important. All right, so we know linkage is an essential component of like the HIV care continuum and the HNS model that helps to, one, preserve health. It helps aid in the quality of life, and it helps to lengthen life expectancy while reaching viral suppression. And effectively no risk, viral suppression is effectively no risk of transmitting the virus. What messaging does your agency use to support viral suppression or effectively no risk?
So I can say that one of the messages that we use as an agency is just straight up telling the client. I think that's something that Levy and I have successfully incorporated into our counseling session, which is explaining to the client U equals U regardless of their HIV status is or is going to be. So this is something that we tell everyone when we counsel them this. We tell them IR, we explain to them PrEP and PEP. So these are pieces of information that are required for us to tell our clients, and which I think a lot of agencies could take on as well. The fact that, we are sexual health educators as well. So I think that's one of the messages that we are proud to always, put on out there.
Thank you.
Yeah, U equals U for sure, I would say is the big one. And, you know, we have like some posters and things about it, but I think that it's also been talked about a lot amongst the providers and citywide, that the providers need to be stating that every visit and like going over that, making sure people understand it, like hopefully also believe it because it's fact. So I think that that's been huge because there have been some surveys done recently in the city where a lot of people living with HIV took these surveys at different clinics and either hadn't heard about U equals U or didn't really believe U equals U, or the way they had heard about it was from a friend or something and not at all from anybody within the clinic. So that's really the main thing, at least in terms of like talking about, you know, reaching viral suppression and everything. That's our focus, I'd say.
And we explain to our clients not only how viral suppression can eliminate the spread of HIV, but how it prolongs life. The aspect of being healthy and letting clients know, you know, viral suppression equals whatever you want to do in life, and you don't have to worry about the naysays of HIV. That's what I want to say. Call it the naysays of HIV. And you know, although you a lot of time people still get hooked up on what's going to happen because I'm HIV positive, and a lot of people think that you know, because they have all this new medication here and there, that they'll do fine. Yeah, you can do fine, but you can only do fine if you adhere to the treatment.
Thank you. Right, because I think that sometimes that messaging gets lost. Right, you can get the medication, you just got to swallow the medication, right, to become undetectable. Right, and then that makes you again, it helps preserve your life and it helps preserve health and then extend life expectancy. Right, so now we're talking about viral suppression. What does your agency do to support serodiscordant couples, right? And for persons who don't know what serodiscordant couples is, that's if, you know, in a relationship, one partner is living with HIV and another partner is HIV negative, or partners are HIV, because we're sex positive here, right? So you might have multiple partners who are HIV positive and other partners who are HIV negative, right? What does your agency do to support serodiscordant couples?
Yes, so I'm going to start. Again, as I mentioned before, there are 4 pieces of information or pieces that we have, you know, that we have incorporated into our counseling. So as I said, it was U equals U, it was IART, but also PrEP and PEP. So that's, I think, a conversation that people should have. As you know, as some of you were mentioning, a lot of people don't believe in U equals U. So for the sake of them not believing, PrEP could work as, you know, an assurance that they will stay HIV negative. So there's always that conversation going on, you know, around couples. So for us, it is very client-centered in the fact that they are able to hear what their actions have been, also makes them aware of their responsibilities. So I think it has a lot to do with that as well.
Here at PALS, we have a PrEP clinic, and as well as we have couples testing. And if we have anyone that tests positive, you know, we automatically have that conversation and discussion with them about getting that their partners getting tested and providing services, early intervention services for those persons who may not have test positive, and offering PrEP with or without health insurance.
Thank you. Are there any, what do they call, evidence-based interventions or high-impact prevention that is offered at your agencies for serodiscordant couples that any of you may know of?
I mean, we have a couple of different like peer navigator programs that are accessible regardless of HIV status. So I don't know if those have really been with couples though. I feel like they're usually one-on-one with the counselor. But yeah, I mean, people could be referred to that either way. And then also, I think that they do like the CLEAR counseling program. I feel like some of that stuff does have like, you know, motivational interviewing or the high impact prevention stuff that you're talking about. So we have a couple of people that they work in our prevention department. So it's sort of tied to the testing department, but anyone can get referred to them if they want to like do these counseling sessions and things like that.
Yeah, thank you. I mean, because in addition to what Sarah said, like testing together is one of those, and what you're saying too, Katie, testing together is one of those interventions that, you know, that help, that are there to support serodiscordant couples, right? So we know that there is a difference between linkage and retention, right? So in South Carolina, we know that there are probably 6,000 people who are out of care. And this number varies by state. What re-engagement practices are available at your agency?
Well, with PALS, we have a program called Early Intervention Services. And those services are consist of a specialized medical case manager and outreach worker. And what we do is we get that outreach worker to, we look for those folk who have dropped out of care. When we look at some of our databases, we see that it could be databases from our Hopper program where we have folk who have not been recertified for ADAP or who's uninsured we hadn't seen. So we send that outreach person out to go and find that person. We do a return to care assessment to find out why that person fell out of care, give them the medical case management, and that medical case management provide or enhanced plan for them to get them back into care, and, you know, try to knock down the barriers that kept them out of care.
Thank you.
So I would say the state itself for Louisiana has some linkage coordinators like throughout the state who, when somebody has been out of care for 6 months or if they never linked, I think, they try to track those people down. So they are running lists like that. And then in our agency, you know, one of our quality people ran a list and then matched it with the state database to weed out people who were deceased or who we knew had moved out of town and things like that. And we have a community health worker who we gave that list of like 300 some patients to, for her to try to go through that list and like call, text, email, call the emergency contact, whatever, for those people and try to get them back in. But I think that that's really hard. Like the people that have been out of care for a while, a lot of times the phone numbers aren't working anymore. And then you call the emergency contact and their phone number doesn't work anymore. And so that's tough. So something that we've just started, and it's just a pilot right now, but that we're hoping to do agency-wide is like a retention program that is before people have totally fallen out of care. So right now I have 2 community health workers who are helping with the pilot where I assign them each one provider and they look at that provider's schedule. And the second that there's a no-show, they then reach out to that person and try to reschedule them, try to say, you know, if there's an opening later that day, that's always what I recommend. So I try to say, hey, it looks like you missed your 11 o'clock. Can you come in for 2 today? Like, I'll see you. You're not off the hook. Like, come on. And then the next day or whatever. And then once they've rescheduled them, reach out on the day of that rescheduled appointment to remind them again, see if they're going to come that day, you know, if not, why not? And also offer a ride because we have access to a Lyft account. So we just started this February 1st. So, you know, it's been like 8 patients or something. It's like just the beginning of the pilot, but we're hoping to expand that agency wide because getting them, you know, when their phone numbers still work and when they still have an appointment and stuff like that is just so much easier than when like 2 years has gone by. Yeah. So we're trying to, we have the out of care list, but we're also trying to like stop, you know, the faucet leak of adding more out of care people. So that's one of the ways we're trying to do that.
Thank you.
Well, for us, it's we have our own follow-up process in regards to it's the same thing that was just mentioned, that with our partners specifically, we set up the appointment together with the client. We assess the person's availability. The day of, we follow up to see if the person made the appointment. Depending on how depending on the client, for example, you might have a sex worker that might not have a phone. They might be on Grindr. So we have our own outreach in Grindr. So it's in terms of meeting the client where they are, and you know, try to assess that as well. And one thing that we also do in our post counseling when it comes to new reactors or out of care is called ARTIST. ARTIST is antiretroviral treatment and access to services. So it's a client-driven approach where we have at least 5 sessions to assess the barriers, make goals with them, you know, basically molding a session to their needs rather than molding the client to our cookie cutter mold. You know, and that way it helps increase that success rate when it comes to linkage to care, or if not, re-engaging them into care. We try to address whatever possible barriers we can before that even comes up, so that way it doesn't even become a problem in the future.
Yeah. Thank you. All right. So shifting gears a little bit to talk about social media and data. I think these are two very important things for all of our agencies, right? What role has or do social media play in your linkage processes, if any?
So I think social media has been really great to us. I think most of our clients here come from word of mouth, but a lot of them also come, you know, from finding us in social media. Each and every single person on the team here has a Facebook account that is connected to our work, you know, like a work account that the clients can find us through. And also the fact that we are always posting. We quite literally post every day there. So they not only know that we are here, they know that we are always here, which I think can make a big difference. So definitely a lot of out of care people have found us that way. And also we've been able to keep in contact with people who we've already linked in order to see how adherence is going and everything. So yeah.
I just say, I think that's awesome that you guys are doing that. I mean, we don't have any social media stuff really. I mean, we have the agency, you know, post some stuff on Facebook, but we don't have anything like specific in terms of the linkage or retention aspect. And I've tried to ask, I don't know, I think they're a little worried about rules or what, because I've tried to ask, you know, can I, like I have a guy who's been out of care now that I linked to care for the Rapid Start program. He's been out of care. None of his phone numbers work, and his friends' phone numbers we have said you can only reach him on Instagram. I was like, can I DM this guy or what? Like, you know, and my agency was kind of like, well, we don't really know, you know? So I think that that is awesome that you guys have those Facebook pages and stuff. I think that would be really helpful. I sometimes look for people on Facebook if they've been out of care, just to see if it's going to say like that they live in Ohio now or something, then I might have an idea. Or, you know, like if something crazy happened, then like sometimes somebody will post that and then I might have an idea of what's going on with them. But I haven't like tried to contact them through that because I wasn't really sure how I could do that. But I do know that like our DIS agents, like the disease intervention specialists and stuff, sometimes like reach out to people using different ways like that. So I think that's great. You have Facebook pages. I think our prevention people and stuff should get on that too. So.
Here at PALS, we've been doing a lot of marketing through social media. We have some staff who they are putting out prevention messages and invitations to testing events. And we also use, with our early intervention services, we use sites such as Being Verified to find clients, Facebook, whatever site we can find somebody, we can hit somebody up, because a lot of time we have clients that's out of care. If they're not answering their phones, if we hit them up, DM them, they may say, sometimes they say, "Who is this?" So you get a response. Once you get a response, then you can get, at least being able to have a conversation with them about getting back into care. But we have some staff that do out on Instagram and some of these other social media sites that I don't know anything about. Every week, because we have that non-traditional testing on Tuesday evenings, and they let people know that the clinic is open and what we are offering on Tuesday afternoons.
And I think in terms of marketing, I think that we do sometimes put ads on Grindr, but I think that might be one of the only ones I know about.
Yes.
And I think it's important, right, to have these conversations with your supervisors, or if you're the supervisor, with your staff, right, around how can we improve our services, right? How can we reach out, especially as it relates to linkage and retention, reach out using different social media sites, but make sure that we're using an agency social media site and not necessarily like Sean Torres trying to reach out to John Doe, right? Because, right, that might be a little off-putting to people, right? So what is the policies and procedures of your agency to use social media in that way and specifically for that purpose? So thank you. Now, what evaluative practices are in place at your agencies to assess your linkage processes?
I would say, our way of keeping track of the people tested that we're then trying to link and like what our linkage rates are is we use an Excel spreadsheet. So it's not like it's the fanciest, but yeah, that's the basic one that, when somebody tests positive, or is referred to us, we'll add them on there, and we'll put, their data of seeing the provider or something basic to have a master list. And then sometimes for deeper data things, we have a more expansive Excel spreadsheet where we put in more demographic information and stuff like that, if we're trying to look for that in terms of, for a conference or something like that. Otherwise, I say, we have the state testing forms that get turned in to the state, and that helps assess like the linkage process, because we also fill stuff out to show whether somebody accessed services within 30 days and things like that. So the state keeps track of the stuff from testing, and then we keep track of our own like linkage numbers as well to make sure that they match up with the state and things like that. But just Excel, that's our main thing, really.
Katie, don't feel bad. We use Excel spreadsheets too, especially with the testing program, and we also use the CDC system, Evaluation Web, to track testing and linkage. Now we use Provide Enterprise for our linkage to care services and our early intervention services. We are able to track all those clients through Provide, as well as figure out, that system can kind of figure out and tell us whether a person is in or out of care. So that's a good thing about Provide Enterprise.
Can you maybe explain real quick what Enterprise is? I don't know if I know.
It's Provide Enterprise. It's a system that.
Oh, it's called Provide Enterprise.
Yes, it's called Provide Enterprise, and it's used by the state DHEC by DHEC, our Department of Environment and Department of Health, Environment and Control. It's one of the funders of one of the state funders.
So for us, we use Evaluation Web as well. That helps us keep track of our data. One thing that we do also to help us better manage our data is in Evaluation Web, there's a reflex report that we can produce. We transfer it over to an Excel spreadsheet, helps us organize it a little better. It's the raw data technically. And we also manage with SPSS, so that way we can see any disparities and where there might be human errors, where we can cross-check. We also have our own file cabinet here, so every time a person's tested, we have the person's information, we have the test, we have copies of the information with their results, their IDs, things like that, so that way we can cross-check. And with that, we can also cross-check what has been checked in terms of referrals, and we'll see if they equal each other, to make sure that everything is crystal clear on both ends,
Thank you. And I think I like the both ends of the spectrum, right? We're using pen and paper, we're using Excel, or we're using a very complex system, right? But I think the takeaway is make sure that we're keeping track of all of this information, right? I think that's the most important. However your agency is tracking that information, make sure it is tracked, right? Because those things are important, right? When you're looking for more funding or you're looking for other opportunities, right? I think those numbers and the way that you track those numbers are important. So in which ways have that data strengthened your linkage services?
So, as Levy was mentioning, once it's on SPSS, we can definitely run syntax on it and see the data, based on whatever demographics or whatever is their HIV status, and also the status of their linkage to care. So I think what we've been able to do with this tool, which with SPSS, is not only see what is not working, and try to fix that, but also see what's working and reinforce it even more within our agency. So I think that's data has been very, very useful to us in that sense.
I think that the data has helped because, one, it's just you need it when you're trying to report on what you're doing. Like you're trying to, how do you know if you're doing a good job or not if you don't have the data, right? But also, for us, I think, we have through the state and through the testing forms and through EvalWeb, we have certain information based on linkage from testing. But for us personally, we also get referred people, right, from other agencies and things. And so if we weren't keeping track internally, like we wouldn't be accurately capturing that we're actually linking more people than it looks like we're linking. And like where those people are coming from. So we keep that in our spreadsheet. And then that's also helpful for me to know, like, oh, maybe I should reach out to, Daughters of Charity or something, because it seems like they're referring people to us. Maybe we should have an official MOU, or, it would be helpful to go over and talk to them so that they understand the process more, or different things like that. So, keeping track of that has been helpful. Also, for us specifically, I feel like the diagnosis date, putting that in that spreadsheet has been crucial, because within our electronic medical record, like you can't really find that information. So then you're trying to keep track of this thing and you don't even know like when they were diagnosed because the provider didn't put that in the note. And they got to you because somebody called you from Planned Parenthood or something. So, putting that information in as soon as you get it, because you forget it later, and all of that has been helpful. And then the one other thing I want to say is going through the data has, I think, greatly increased our retention numbers, because we regularly will go through like our linkage data to see if these people are still in care, if they're virally suppressed, like what's going on with them. And we'll notice, oh, well, they went to their first 3 appointments and they've since fallen off. And because we regularly review that data spreadsheet, then we can go back and reach out to them again, try to re-engage them. So we're keeping track of like just that specific group of our patients, but we have like our linkage coordinator going through that list. And so that has, I think, single-handedly increased our retention numbers because that person is going through the list and reaching back out. So I think that's been really helpful.
For us, I think it's helped keep us on track of and of what's working and what's not working, and that so that we have a chance to modify any services that need to be modified when we see some of the things that we're doing with Linkage to Care. If it's not working, we are able to change it in a timely manner instead of waiting until at the end of the year and you look at all the data at once, you know, especially with looking at in my provide system, I can see when people dropping out of care, people have not seeing their providers, because we can always see all the progress logs and from the physicians as well as from other case managers.
Thank you. And we're coming to the end of our time together. It has been a joy and a pleasure to be able to lean on all of you's your expertise in this matter, right? And we've had a couple laughs, we have some jokes, but most importantly, I thank you all for doing the important work that you're doing in your location in South Carolina, in New Orleans, in New York City, and other places. And even those of you who are watching throughout the country, thank you for the work that you're doing. And now, one thing that we're going to ask all of our panelists to do is give one final takeaway that you would like the persons who are watching to know from this conversation.
So one thing that I would want to for all viewers to actually take away from this is that linkage is possible. You know, it's available regardless of status of your immigration, regardless of your insurance status, your gender, you know, etc. Things like that aren't a barrier, you know, to getting linked. You know, and that ties me to my second thing. You know, as us as providers, we need to understand that the client's perceived barriers might not necessarily be the actual barriers, and that's our job to help them see that. That's what I want them to take away.
Thank you.
I think for me, I think it's just so important when linking folks to care is to be proactive in engaging and re-engaging persons into care. You know, sometimes we wait for a long time. Why do we have 6,000 people out of care in South Carolina? Shouldn't be. And I think it's because we was not paying attention to those that was dropping out of care. Making sure we folk that come in test positive always get a referral right away, and instead of having them wait months at a time before they're seeing a provider. You know, sometimes clients start feeling real well and feel good about themselves and say, you know what, I really don't need no care. So we lose them before they even get into care.
Thank you.
I like the things you guys said, and they are sort of on a deeper level, which I think is nice. I just wrote down 3 little short things that, just practically speaking, have, I think, made a huge difference in linkage, which is having an Uber or Lyft account. Like, I know these are all things that are resource dependent, but I mean, it has made a huge difference in people making it to their appointments. And also, I've had people that they try to use that as their excuse, and I'm like, well, I'm sending a car to you right now, so let's get in it, let's go. And then I think the immediate ART program we have that has, you know, been expanded, like it's starting to happen all over the country. Getting people on meds that first day really helps with U = U and lowering the community viral load. And empowering the person that day, like they're already taking steps to being healthier themselves. And then the third thing was the ability to text, because having a work cell phone, I think has made a huge difference. I have we have a team of case managers, and they cannot reach the clients the way that our linkage person can, because they have a work cell phone and can text them. And so if there's like any way within your agency to get some kind of a texting ability, even if you're doing it through the computer, like through Google somehow or something, like I think that those three things make a huge difference at getting people linked quickly and more easily. So.
And Frank, did you have anything to add?
Yes. So again, just all of you are absolutely right, especially with the texting. I was just texting a client actually about Linkage. He's an out-of-care client, and he had some doubts. So yes, that, and also I think also something to take away would be just collaboration. I think just even this sharing all our knowledge and information just can help so many other people to take away stuff that they can incorporate into their organization. So I think collaboration, MOUs, whatever you can find within your area in order to make your job easier and to make the client more satisfied.
And I think two things that I want people to take away from this conversation is, one, that linkage doesn't only happen one time, right? And if you think linkage happens one time, just expand our minds, right? We might have to link, relink, re-engage, and relink again, right? But we're not only relinking to one service, but we're linking to multiple services, to other supportive services, right? And then the second thing that I want people to take away from this conversation is this idea of destigmatizing linkage, right? Because HIV positive persons are not the only people being linked, right? Thanks to PrEP and other supportive services, HIV negative persons are also being linked, right? So linkage is status neutral. So I think that's also an important takeaway. But thank you all for sharing your expertise with us on this live. On behalf of the Latino Commission on AIDS, we thank you for the work that you are all doing in your respective areas. Thank you, Sarah. Thank you, Katie. Thank you, Levy. And thank you, Frank. From Hands United at the Latino Commission on AIDS, we thank you all so much. Thank you, and have a good day.
Thank you.
Thank you. Have a good one.
Bye, guys.
Bye.